Hi, welcome back to this third and final part of the introductory psychopharmacology lecture for N232.04C. I'm Andrew Penn. I'm a psychiatric nurse practitioner and associate clinical professor at UCSF. So this is going to be the most technical aspect of this lecture. We're going to talk about pharmacokinetics. And pharmacokinetics is where kinetic refers to movement. We're talking about how does the drug move around. How does it get into the body, first of all? How does it move around the body? And then how does it leave the body? This is sometimes referred to as absorption, distribution, metabolism, and excretion, or ADME, as you can see here. So we're going to talk about this specific to psychiatric medications, but much of this is applicable to all medication classes. So the first question is, how does the medication get into the body? The vast majority of medications that we are going to prescribe in psychiatry are going to be orally prescribed, although there are a handful that are injected, both IV and intramuscularly, either as emergency medications such as intramuscular antipsychotics or benzodiazepines, or long-acting injectable antipsychotics. And increasingly, the future is probably going to involve infused medications, ketamine being the most common one right now, but there are several others in the pipeline. So don't be surprised if your future in psychiatry requires IV skills, which is great as nurses. Most of us are at least capable, if not skilled, at starting IVs. So the where the medication comes into the body is important because there are variables that influence how much is absorbed. So for example, the pH of the stomach, if the stomach is inflamed in the case of gastritis, and then also how much time does the drug have in contact with the tissues where it is absorbed. That's sometimes referred to as transit time. So if transit time is shortened in the case of diarrhea, that medication is going to have less time to be absorbed. This is also important to bear in mind if somebody has had a gastric bypass, because they're going to have less gut length for the medication to be absorbed, and they may need higher doses in order to get the same absorption, to get the same amount of drug absorbed as somebody who has a normal length gut. So just a quick review of the portal vein, because this is important to understand the anatomy, so that we can understand the physiologic process of drug first pass metabolism. So if you remember back to your anatomy class, remember something called the portal vein. Now, as you can see in this diagram, essentially all surfaces of the gut where nutrients and what's relevant to our conversation here today, medication, are absorbed, are picked up by the portal vein. And the portal vein goes right into the liver. It does not go into the systemic circulation first. So things must go through the liver before they are released out into the general circulation. Now, this is a very smart adaptation that evolution has provided us with, because if we eat something that is poisonous, we're more likely to survive that if our liver has a chance to detoxify it before it enters our systemic circulation. The problem is that it also makes it difficult to get medication into the bloodstream, because the liver bats first, is a way of thinking about it. So before that medication can move into the inferior vena cava to the heart and then be circulated around the whole body, and particularly to the brain where it's relevant to our purposes, it's got to go through the liver. So this is known as first pass effect. So oral drugs have to go to the liver first. Now, obviously, IM and IV drugs do not have this first pass metabolized effect, nor do inhaled drugs such as cannabis when it's used in a smoked or vaporized form. So usually we talk about a percentage of first pass metabolism. So if 50% of a drug is lost to first pass metabolism, assuming that it's 100% absorbed. So if a drug is 100% absorbed and 50% is lost to metabolism, then we have 50% of the original drug dose now in the systemic circulation. So there's another factor that comes into play here, and that's called distribution. So most drugs are bound to protein. The most common protein is albumin. Albumin is synthesized in the liver. So if somebody is in liver failure and they are not producing very much albumin, what that means is that they're going to have less of that drug bound to albumin because there's simply less albumin available to the body. And it's only the unbound fraction of the drug that is able to actually have its desired effect. So when drugs are bound to protein, they are not, in effect, active. But drugs are constantly being dissociated or released from albumin over time. So um, the amount uh, of albumin available, it's not generally something we measure unless we have a concern that that person is not producing enough albumin because, for example, they're in liver failure. So albumin is the most common. There are other proteins, but it's important to keep this in mind when we're talking about impaired hepatic function, which is usually why we use lower doses in somebody who has liver issues. So volume and distribution can get kind of complicated, but essentially the concept that I want you to have down here is that we're talking about where does the drug go? How is it distributed in the body? Does it largely stay in the bloodstream or does it come out of the bloodstream and get deposited in the tissues? So if a drug is listed as having a low volume of distribution, usually abbreviated VD, then it largely stays in the bloodstream. A high volume of distribution means that the drug is largely distributed in the tissues. And one of the reasons why it gets into the tissues is because it's able to cross the cell membranes. So remember, the cell membranes are a bilipid, meaning they're two layers of lipid cells that comprise the exterior of cells. So if a drug is lipophilic, what that means is that it can easily cross over that fatty membrane, which means it's more likely to be deposited in the intracellular component. Excuse me. So one of the most important barriers that we encounter in pharmacokinetics is the blood-brain barrier. So the blood-brain barrier is made by the astrocytes. The astrocytes are one of the three types of glial cells. So uh, those are cells that exist in the brain that are not neurons, so astrocytes. And as you can see here in this diagram, they have these sort of like feet, that sort of coral yellow colored part of the diagram, which wrap around the blood vessel to create these small gaps that allow for uh, particles that are small, lipid soluble, and not highly charged to cross over. So this is one of the challenges of psychopharmacology, is that not only does the drug have to have an effect in the brain, it has to be able to get to the brain first. So if the drug can't get past the blood-brain barrier, it can't have any effect for us from a psychiatric standpoint. So the blood-brain barrier is also an important adaptation from nature, which which prevents, kind of protects the brain from just any old molecule being able to get out of the bloodstream and get to that very vital organ. But it does make development of a drug that can cross the blood-brain barrier that much trickier because it has to be able to get through those small gaps and be easily cross over a lipid barrier. So there you go. There's that bilayer cell membrane. So why does that matter? Well, one place where you'll definitely see a clinical effect is in the use of benzodiazepines. So benzodiazepines all do the same thing at the end point. We'll talk about that in the anxiety, what they actually do in the anxiety talk in a few weeks. But what I want you to pay attention to here is this middle column of lipophilicity. So in here, what we're looking at is how easily does that benzodiazepine molecule cross over the blood-brain barrier so that it can begin to get to work. As you can see, diazepam and alprazolam and temazepam are all very lipophilic, which means that they cross over quickly. What does that mean for the patient? It means the patient will notice a change more quickly than, say, if they're taking a less lipophilic drug like clonazepam. So this is why patients will often say that diazepam or alprazolam, quote, work better than something like clonazepam because it crosses out of the blood into the brain faster and gets to work more quickly. So let's talk about how drugs get broken down. So that's what's meant by metabolism. When we talk about drug metabolism, we're talking about the breakdown of drugs or the preparation for them to be excreted from the body. So generally what it's doing is it's making that molecule more water soluble so it can leave out through the kidneys and out of the body through urine. And there's usually two pathways that a substrate, which is another word for a drug, will be broken down. So those are the cytochrome P450, sometimes referred to as CYP P450 or P450. Those are all shorthands for the same thing. Or the less talked about gluconeryl transferases or GTs. So in both cases, what these are doing is they're taking the substrate and they act like little machines. They break down the drug. Now, different drugs go through different pathways. We'll talk about that more in a minute. But their breakdown results in a metabolite. From the metabolite can then be excreted, typically in urine, but sometimes in stool and sweat or through the lungs or even in breast milk. Now, when we're talking about the cytochrome P450 system, we refer to these genetically coded enzyme pathways, and they have these somewhat cryptic, but you'll quickly become familiar with these terms like 2D6, 3A4, 2C9, so etc. So these are refer to the pathway which will break down a specific drug. Now, the speed at which these little machines work at can vary somewhat. There's some variability from person to person, and there's some factors such as smoking, for example, will increase the speed at which many antipsychotics are cleared. So there's some association with racial ethnicity. And so what these are doing is, so if somebody, for example, is a very fast metabolizer, what's going to happen is they're going to go through a drug much more quickly than somebody who is a normal metabolizer. And what that's going to look like clinically is that they're not going to have as much benefit from that medication than somebody who metabolizes it more slowly. But somebody who's a very slow metabolizer, what's going to happen there is they're going to end up with the drug building up in their system, and they're going to end up with a lot of side effects, more so than somebody who's a normal metabolizer. The gluconeryl transferases are these conjugation reactions where an enzyme, the gluconeryl transferase, attaches, will make these molecules more water soluble and easy to excrete. So let's take an example of this. So cytochrome P450 2D6, a very common pathway for many psych meds. So a common substrate for that would be venlafaxine, which is also known as Effexor. So that is broken down by the cytochrome P450 2D6 enzyme. So it goes through there, it's broken down into something called O-desmethylvenlafaxine. Now, if you're paying attention, you may notice that that is the name of a, quote, newer antidepressant drug that's marketed as Pristique. So that is the first metabolite. It is an active metabolite of venlafaxine, O-desmethylvenlafaxine. So that then is then excreted from the body. So let's take another look at this. So let's take the example of a medication, very common, hydrocodone, Vicodin. Now, hydrocodone is a prodrug for hydromorphone. So it goes through the 2D6 pathway and it becomes hydromorphone, which is more commonly known as Dilaudid. That results in pain relief and then it's excreted from the body. So what happens if we take the 2D6 and we introduce an inhibitor? So venlafaxine actually slows down the rate at which 2D6 works. So that's known as an inhibition reaction or inhibitor. So what's going to happen is you bring this in. Let's go back for a second. So now we bring in, somebody's taking Vicodin, it's breaking down into hydromorphone, they're having pain relief as a result. We now add venlafaxine, an inhibitor. That's going to make that 2D6 pathway process that drug more slowly, which is going to result in decreased hydromorphone conversion. And practically for our patient, clinically, what we're concerned about is that that could result in decreased pain relief for that patient. Now this can work with the gluconeurol transferases as well. So a substrate for the gluconeurol transferases is lamotrigine or lamictal. Okay, so when that's going through, it breaks down to N2 gluconoride and is excreted from the body. Now, if we introduce, so let's say your patient is taking lamotrigine, and then you introduce carbamazepine, which is Tegretol, another mood stabilizing medication. Now, carbamazepine is a inducer of the gluconeurol transferases. So now you've got that machinery going at a much faster rate, which means if that person was taking lamotrigine for their mood, we might see a relapse into depression. If they were taking that lamotrigine for seizures, we might see them at higher risk for having seizures again. So the clinical bottom line here is that in order to keep the lamotrigine dose, or the level, I should say, the serum level, the same, you have to double the dose of the lamotrigine when you start carbamazepine. Otherwise, you run the risk of having the symptoms that you were treating with lamotrigine return for the patient. You might need to go back and run that through one more time. It's kind of a complex set of events, but listen to it again, it will probably make more sense. Here's another important clinical drug-drug interaction. So let's say the person is taking birth control pills, oral contraceptives. Those are typically broken down by gluconeurol transferases. So fine, those are broken down, they go out to the kidneys and urine, and they're excreted. Now, we bring in carbamazepine, which, as I mentioned before, was an inducer of that pathway. So now that gluconeurol transferase is going at a much faster rate. What happens to the birth control pills? They're broken down faster. What happens when they're broken down faster? They're less effective. So the take-home message here is if you want to avoid an accidental pregnancy, if they're taking carbamazepine and they're using oral contraceptives as their means of preventing pregnancy, they need to use a backup method because those oral contraceptives are going to be less effective in the presence of carbamazepine because of that gluconeurol transferase induction. Now, another key concept to understand in pharmacokinetics is known as area under the curve. Now, area under the curve can be thought of as the total drug exposure over time. Now, you can see when they contrast here IV and PO that there is a distinct difference because of the way that those two drugs are distributed. So obviously, when you give somebody an IV at time 0, when you give the drug, you are at maximum concentration of that drug because it doesn't need to be absorbed through the gut. And then as the drug begins to break down, we see the level drop off as in this red line here. Now, with an oral, if the drug is given orally, there's obviously some time between when the drug is maximally absorbed and then when it starts to drop off. And obviously the level of the drug is lower in an oral form because of first pass metabolism. So let's take this down a little further. So we see some key times here. So this right here at the bottom left corner is when the drug is actually taken. Now, these dotted lines, this is the maximal therapeutic concentration, and this is the minimal therapeutic concentration, this dotted line below it. So we can think of the space between maximal and minimal as the therapeutic range of the drug. When the person begins to feel the effect of the drug, we call that onset. Okay, time to peak is the time, or sometimes referred to as Tmax. That's the amount of time between when the drug is taken and when it actually hits the maximal concentration, or Cmax, in the bloodstream. And then it begins to drop off over time. So this whole area, which is shaded gray here, is referred to as area under the curve. So let's take an example. So if a drug has this is important for understanding the concept of half-life. Now, half-life is the amount of time it takes for the drug to drop by 50% in the bloodstream. So in this example, let's say this drug, for purposes of simplicity, is 100% bioavailable. It's entirely absorbed by the gut. And it has a half-life of 10 hours, and the dose is 200 milligrams. So what that means is that because it's 100% bioavailable, and that's uncommon for the record, but let's just say for simplicity that it is, then at concentration maximum, we're going to have 200 milligrams in the bloodstream. At 20 hours after taking the drug, we're now going to have 100 milligrams because we've dropped by 50%, right? And then another 10 hours later, we're going to have 25% of the original dose, or 50 milligrams still available in the bloodstream, 25 milligrams at 40 hours, and 6.25% of the drug, or 12.5 milligrams at 50 hours. So another way of looking at this is, okay, so here we go. We have an example where it's 100% absorbed, but there's 50% first pass metabolism. So the liver takes half of it out right at the beginning, okay? And it has a 12-hour half-life. So it's 100 milligrams of this made-up drug called Hexterol. We'll say, okay, so 100% absorbed, but 50% first pass metabolism. So now we're starting with only 50 milligrams. After 12 hours, we have 25 milligrams left in the bloodstream. After 24 hours, we're going to have 12.5 milligrams left in the bloodstream, and so on and so on. So as we go up with each dose, because obviously in most cases we're not just taking one dose of the drug, we're taking it on an ongoing basis, you're going to see this stepwise increase till we get to what's known as steady state, where there's a fairly consistent peak and trough each day as we've gone up on the drug. And that typically takes 5 half-lives to get here, okay? Now this is relevant particularly if we're measuring the level of a drug. So for example, lithium, valproate, carbamazepine, all common mood stabilizers, are dosed with the help of drug levels. Now here's the problem. Do we tell the person just go to the lab any old time? Well, if they went to the lab a couple hours after taking the drug, they're going to be at the peak. If they go right at the end of the day, right before they take their next dose of medication, they're going to be at the trough, or they could be somewhere all over the place. So how do you interpret that data? Well, we have to have a convention as to when they go get their blood drawn. And in these cases, we use trough levels. So the clinical take-home instruction is you need to be taking this for 5 half-lives, which with all these drugs is 5 days. It makes it very easy to remember. So I say anytime after 5 days, you go to the lab in the morning, right before you take your next dose of your medication. Now, if it's BID dosing, you could conceivably do it at the end of the day too. However you want to do it is fine. But it needs to be right before the next dose because that's going to be your trough level. And that's how we can compare apples to apples, because otherwise, if we get random measurements, then we're not going to be able to compare them to each other. I want to talk just briefly about biotransformation and the idea of active metabolites. I mentioned this with the example of venlafaxine. So for example, when the body breaks down a drug, it can make these active metabolites. So here's kind of a trick question. Your patient's taking diazepam. You get a tox screen. So diazepam is Valium. And they come back positive for temazepam, which is Restoril, and oxazepam, which is Serax. Are they taking 3 different medications? No. What they're doing is they're taking diazepam, but the body is breaking it down into these active metabolites of temazepam, oxazepam, and another metabolite called nordiazepam. All 3 of these continue to work on the GABA receptor, just like the parent drug diazepam. But these are what are known as active metabolites. And these also have to be cleared from the body. This is one of the reasons why we tend to stay away from diazepam with older patients, because these active metabolites can also build up and cause things like falls and confusion. Another example, as I mentioned before, would be venlafaxine, which is broken down through the 2D6 enzyme into desvenlafaxine. Okay, and that is also sold, that active metabolite is sold as a unique drug called Pristique. But as you can see, it's really not anything new because really what it is the first breakdown product of venlafaxine. And finally, elimination is how the body gets rid of the drug. So some of the drug is just going to end up leaving out through the stool because it didn't get absorbed. So typically you don't have 100% absorption of drugs, and some of it is going to leave the body unchanged in the feces. But then the rest of that drug is made water soluble by the metabolism process of typically of the liver, as it is excreted by these other uh, pathways, typically urine. So again, this is one of these places where we have to pay attention when we're treating a patient who has impaired renal function, because if they can't eliminate the drug, it's going to make it build up in their system and potentially give them more side effects. So one of the things I'm going to have you do in your homework is to pick a drug, look up the PDR for it, and then look in section 12.2. And this is where the pharmacodynamics and pharmacokinetics are listed. So this will start to tell you where the drug actually has its action, which is what we're going to be talking about in the lecture next week. Because really, what we need to remember is that while we want the drug to act in the nervous system, specifically in the brain typically, our drugs have other, they hit other targets. And this sort of collateral damage or scatter, if you will, is what causes a lot of the side effects with drugs. And we'll talk more about that when we get into receptor pharmacology next week.